Thank you all for coming, and welcome to our sort of second virtual fireside chat. I know we've got people from Indiana and Toronto and Eldoret and probably other places as well. For those of you who don't know, I'm Adrian Gardner. I'm the Executive Director for the Ampath Consortium, Director of the IU Center for Global Health, and I'm here in Indianapolis with my daughter's recreation of our fireside picture here behind me. Which is hopefully will become a little tradition for these virtual fireside chats. But I think most of you know I spent the last 7 or 8 years in Eldoret, Kenya, where we held these fireside chats in person, and they really provided a space to learn and reflect for our trainees and visitors. And sometimes they were inside around the fireplace, sometimes they were outside around the fireplace with John Humphrey making kettle corn and lots of extra treats. So we don't have quite the same luxury in this virtual world, but we'll take what we get. So, today we're going to hear a bit more about Ampath's work in women's health and particularly reproductive health. Our work in women's health really dates back in our community-based work in women's health dates back to our early days of the HIV program and PMTCT. And then really took on a new life in 2007 with emergency obstetrics care and gynecology, and really has grown so much, as you're going to hear from our presenters today, both our North American and Kenyan presenters. So our panel, I think, is going to focus on some of the recent projects and initiative of Ampath, and maybe give a brief history of how things evolved. But and just from a technical perspective, I think if we could just encourage you all to keep yourself muted until a time when we sort of open up for questions or comments, that just facilitates everything. So I'm going to ask each of our panelists to briefly introduce themselves, but maybe just to start with Dr. Wycliffe Koskei, Director of the Reproductive Health at Moitz Referral Hospital. Koskei, are you there?
Yes, thank you. My name is Dr. Koskei Wycliffe. It's a pleasure to be here. I think I'll just do a brief introduction. I am an obstetrician gynecologist, pretty much system bred. I learned in Moi University, undergraduate, went to different facilities for internship, and also came back for postgraduate training with MTRH. Rather rose quickly over the ranks. Now I'm Director of Reproductive Health in Moi Teaching and Referral Hospital. I also assist Ampath Plus with a bit of RMNCH, which is Reproductive, Maternal, Neonatal, and Child Health. I'm the project lead for a program that is USAID funded within Uasin Gishu County. So I think that's a brief introduction about myself. I think we'll discuss further when you're having the discussion. Thank you very much.
Karibu. So our next panelist is Dr. Caitlin Bernard, Assistant Professor of Clinical Obstetrics and Gynecology here at IU.
Yes, thank you. I appreciate that. Yeah, so I was team leader for Ampath Reproductive Health in 2014, 2015, after I graduated residency in the US, and really fell in love with the program and realized that this is something that I want to continue to be able to do throughout my career. And so came back to IU after a fellowship in family planning, and have continued to work with Ampath and the program, and have really seen it grow over the past few years, and have learned alongside Koskei in a lot of ways, and we appreciate your involvement and support of our program.
Thanks, Caitlin. We also have Dr. Julie Thorne, Assistant Professor at Department of Obstetrics and Gynecology at the University of Toronto, also a former team leader.
Yeah, hi everybody. It's really nice to be here and to see some of your faces and names. So I'm Julie Thorne. I am working as an OBGYN with special interest in global women's health and family planning at the University of Toronto. But like Adrian said, I was team leader in 2018 and 2019 and moved from Kenya just maybe 2 months before this pandemic broke out. And so it's a delight to be able to talk to you about some of the work that we've been doing and issues that we see. So thank you.
Great. And finally, we have Dr. Elizabeth Riga, who's one of the senior registrars in reproductive health at Moi University. Dr. Riga.
Hi all, I'm Elizabeth Riga. I'm a senior registrar in reproductive health, Moi University. And coincidentally, as my mentor, Dr. Koskei, I also undertook my undergraduate training in Moi University, went for internship in Nakuru, worked in Nakuru, and now back again for my postgraduate training in Moi University.
Great. Well,
And
great.
I have enjoyed mentorship of all the panelists, and looking forward to more. Actually, during the undergraduate years in Eldoret, City of Champions, people run to the finish line and they finish with a kick. But now this COVID, I'm a finalist, yes, but now we are crawling slowly to the finish line, hoping to get there sometime soon. Otherwise, I'm very happy to meet you all, though virtually.
Thank you so much, Elizabeth. So let me turn it over to you guys.
Okay, so the photo that you can see there, that was the younger version of me then during my undergraduate years. Just like every person has a dream, like you aspire to be somebody in this field. I always wanted to be in reproductive health field as an obstetrician gynecologist. And getting to Moi University as an undergraduate student was the it moment for me. But during the training years also, you go through a lot of challenges. And looking at the time when somebody gets transition from the theory in basic sciences to getting to the junior clerkship, that's usually a very, very important and landmark moment. And this shows the time when we got the stethoscope. Now there's usually the stethoscope ceremony where the undergraduates transition from the years of basic sciences to junior clerkship. And this gift is usually very symbolic. It was to me, it still is to me, and I believe also to many people. Working with Ampath or being a beneficiary of Ampath Plus initiatives, and part of it being the gifts that we receive. Many students, as I said, go through various challenges. There may be transitions, maybe during the high school years, somebody gets to realize their dream of being in a medical school. And whenever they run into financial challenges, sometimes it's usually very difficult for people to know, like, where do you run to? Who do you talk to? How do you get help? Or some people start off very well and financially, but circumstances in life change. Some people lose their parents along the way, or they lose their guardians, or the guardians lose their income along the way. And these challenges actually are usually a very big threat to sustaining the education for the students. And thanks to the Mwangaza Scholarship, whose heart and soul, I say, is mom and dad, Betsy and Talbosin, whom I met in 2005 while they were working with still with Moi University under the Mwangaza Scholarship. Then where life happened and situations changed. And thanks to initiatives that have been put in place like Mwangaza Scholarship, I was able to complete my undergraduate studies. And the story about the financial situations is not unique to me. There are people also who lose scholarships that they had before, and they end up benefiting from like work study initiatives that are also really helpful to students. The training years, we interact with a lot of lecturers from Moi University. Some of our lecturers are also staff in the MTRH hospital. And also we benefit from the collaborations in Ampath from the, should I say, visiting lecturers, because I have been taught by Dr. Julie Thorne, Kathleen Bernard, and many others as part of the training, mentorship, and apprenticeship benefits within the Ampath Plus initiative. I have had opportunities to be mentored by Dr. Thorne, and this shows a laparoscopy camp where we were with Dr. Thorne in Tumutumu. Currently in the Moi University program, we do not have an established laparoscopy practice per se, and the skills are far and wide in between. And whenever we get opportunities to learn, we gladly take them, and we have excellent mentors who actually take us under their wing, and we learn the skills that we are supposed to learn. Because in gynecology services, actually now laparoscopy is key, and the lack of an established laparoscopy practice in Moi University is a real gap in training. And during this corona pandemic, the Moi University program was in the beginnings, or was starting to see how it can be introduced as part of the clinical rotations. And we were really happy working with Dr. Mari, booking cases and getting a chances to operate. But now all of a sudden Corona happened, and now we are back to having only one mentor who has the surgical laparoscopy skill in gyne services. So to us, it's a real big loss. And since my class is the pioneer class in terms of having laparoscopy as a rotation, where you have time allocated for you to learn laparoscopy skill, actually we are really short-changed in that aspect. You can see me there proudly holding a certificate in my hand, and that was me when I was in University of Toronto as part of the exchange program in gynecology. There are other elective opportunities from undergraduate years where students go to various universities under the Ampath Plus partnership and collaborations to Indiana University, University of Toronto, and other universities. But for reproductive health, mainly University of Toronto and Indiana University. And these opportunities are actually very good for us. We have fields in reproductive health that are not developed, as I said, laparoscopy being one of them, and some which are very important but have not been established yet. During my undergraduate years, while undergoing the pediatric rotation, there is a professor in pediatrics who used to tell us, when you see children, do not treat them like small adults. These are not small adults. And with that in mind, when I had the opportunity to undertake, to benefit from the international elective, where I was lucky to go to University of Toronto for my electives, I had requested to rotate through pediatric and adolescent gynecology because I needed to learn how this population is handled in matters gynecology. And also I benefited from the fertility rotation because we do not have an established fertility here. When you look at HIV, because most people when they hear the word Ampath used to link it mainly with HIV. But when you look at fertility or subfertility or infertility terms, especially in the Kenyan population, actually it carries, should I say, a higher stigma than HIV, because this is something you see, and women would say like, everybody can see I do not have a baby, or somebody would say this one has a baby and this one does not have a baby. So it was very important to acquire the knowledge and skills, and more so develop better attitudes in understanding as a clinician about fertility. So these collaborations with giving us opportunities to learn about how established practices in gynecology are done actually is usually very helpful. And also the other, next photo please. The other thing that we have largely benefited from is the maternal fetal medicine, or the medicine around fragile pregnancies, which I cannot overemphasize, because we have a guru in the making amongst us, and Dr. Kosgei can take us from there.
I'll ask that we go back one slide. I think I just want to appreciate the input that Ampath Plus specifically has had with the training that we've undertaken. My first interaction actually with reproductive health Ampath Plus was probably a bit earlier, but the photo that I have here is when we were working with Hedda, and I think this was Udia. This was in 2011 when I had just joined MTRH as a medical officer. It eventually grew into my interest in reproductive health, which culminated in me joining the MEd program that was enabled, or rather that was established partly with a collaboration between Moore University and University of Toronto and University of Indiana. So I benefited through that program. The picture on the right is for 2014, when we had an exchange program. This was at Mount Sinai in Toronto, and that was our visit then during the exchange program. Let's go to the next slide, please. So in short, through the collaboration that we've had with Ampath Plus, it has really significantly molded my professional practice. The other thing is that it doesn't also stop there. The picture that you're seeing is on the right is a maternal fetal medicine fellowship, which I am glad hopefully to be able to join and start as a first year fellow. The picture that is having there is for our first year, or currently now second year fellows, Dr. Bet and Dr. Pallavi. And we also have our mentors, Professor Nan, and also one of our other colleagues from University of Toronto. And this is an improvement to the reproductive health program that had been initiated. So not just the reproductive health postgraduate, but even now we are going into MFM, or multi-specialization, that is required to respond to some of the challenges we've had. We've had significant success with the gynecology program. One of our graduates here, Dr. Eli Odongo, who is coincidentally also the chair of the Kenya Obstetrics and Gynecological Society, was a student within our program, and now has actually given us another cap in our training by having qualified as being among the first people in Kenya to be certified by the International Gynecological Society, I think, having undergone an exam, and be the first person within Kenya to actually have that qualification. Let's go to the next slide. Now, subsequently, because of the trainings that we've had, I have become the Director of Reproductive Health within MTRH. The photo there is of our Riley Mother and Baby Hospital. It is the second national referral hospital within Kenya, having a delivery of around 13,000 deliveries per year, and an average of around 1,100 to 1,200 deliveries per month. We've also had a few challenges with it, and this refers also with maternal mortality. So generally in Kenya, we still have a high maternal mortality. Worldwide, we have around 211 maternal deaths per 100,000 live births. Within Kenya, we have 342, the most recent as of 2017. So it's still higher than normal. And if you compare with the North American partners, we have between 10 to 19 per 100,000, and we are hoping to really learn and emulate from them how to improve the system. Next photo, please. This is a photo within Riley Mother Baby and some of the strides that we are trying to do to improve maternal mortality. Through the collaboration, we've managed to start the implementation of bedside ultrasound, or a point of care ultrasound that is available to immediately diagnose problems within the mother or the fetus, and also an NST to be able to assess the fetal status. The picture on the right is one of our maternity delivery beds. This is our labor ward with a mother who had just completed laboring. Let's go to the next photo, please. Also on top of that, we also have training for our residents. The training that we are supporting, both postgraduate, and this is postgraduate training. You are training in this case how to manage PPH, and this is also neonatal resuscitation. Some of our colleagues have actually graduated. They are new consultants in reproductive health, and through the collaboration, we've been able to achieve quite a lot the same. The picture on the right is our newborn unit. It is quite busy. I think a bed capacity of around 60, but sometimes we also go to bed occupancy of around 100. So there's sharing of incubators to be able to manage the number of influx of patients who are coming to deliver within our facility. Let's go to the next slide, please. I'll highlight a bit the challenges that we are having in women's health. The biggest problem that we are having really is a lot of women dying in childbirth, pregnancy and childbirth. Worldwide, I think there are around 289,000 women who still die in pregnancy and childbirth. And that is what we are really trying to address. We also have 1 in 3 women undergoing physical or sexual abuse. This is called sexual and gender-based violence that we are hoping to still address. We have around 225 million women who have an unmet need for family planning, and this is mostly women who in Africa or sub-Saharan Africa. We have around 800,000 women who are dying of reproductive health cancers, and around 28% maternal mortality that results from communicable and non-communicable diseases, most of which are preventable. Our response as Ampath Plus is really to try and pivot to the 3 areas that we think we are good at, that is providing quality care, providing also training, and also carrying out research. RMNCH, which is Reproductive, Maternal and Child Health, is a response and is a USAID-funded program, as I previously mentioned, to try and respond to this. We've also mentioned about postgraduate training that we are trying to do to improve specialized care, especially to handle cancers that we had mentioned, and also to reduce maternal mortality, and also through FP, and also provide a bit of adolescent health that both Caitlin and Julie will be able to discuss about. Next slide, please. I'll mention briefly about the RMNCH initiatives that we are doing. It is not possible for us to stay in the facility and hope to be able to save lives. So through this RMNCH program, we actually go out to the community to be able to try and inform women about their health and how to make sure that they stay healthy, specifically in reproductive health. We have various activities to try and improve community health service provision through the use of CHVs and all the way up to the county government, also to improve health facility delivery and to improve health management information system. Those are our 3 key objectives. The photos there describe a few things. The one on the right is where we are training CHVs on how to use a pregnancy wheel and how to identify whether a mother is pregnant, how to date the pregnancy, and then link the mother to care. But we're also offering a bit of support through chamas. So we take women into groups to try and improve their care and give them information. We will discuss later a bit about chamas. And the picture on the bottom is us training on emergency obstetric and newborn care. So I think in brief, that is the support that we are doing as Ampath Plus and reproductive health. I think I'll invite Caitlin to continue.
Thanks. Yeah, I know that's a lot. I wanted to speak a little bit kind of from the IU side. We don't have any great pictures, but we also do host registrars at IU every other year. So if there's anybody here in the community from IU who is interested in, getting to know our registrars when they come, this year has been really disrupted. We were hoping to have them this year, but hopefully next. From the COVID pandemic, but we really appreciate all of your involvement in their education, as you can see, kind of from the beginning all the way through to being specialists in OBGYN. I think that Riga really mentioned fertility a bit and infertility as being a huge problem that people often forget about. And we were lucky to have one of our own fertility specialists. I think many of you know Dr. Marguerite Shepard from here at IU, who came to Kenya this year and was able to start a bit of some infertility training, and we hope to continue that in the future as well. I think, you know, what makes Ampath really unique is this ability to lead with care, right? That we have a care program that allows us to then center our efforts on taking the best care possible that we can of the patients and the women that we take care of and the families, and then layer onto that training such that we can provide the best training that we can for the sustainability and the sustainable care of people into the future by our great colleagues in Kenya, and then layering onto that research. And so Julie and I are going to talk a little bit about some of the research projects that we have had over the past few years that have, you know, in their aims, not research in and of itself, but how can we improve the care that we provide. The picture down on the left was the first project that I got involved in 2014, when we realized that we had a great need for family planning integration. We were starting these wonderful programs for chronic disease management, like the anticoagulation clinic and the cancer clinics, and at the same time having lots of female patients, and yet had not well integrated how can we help to protect them during their illness until they are healthy enough to become pregnant. You know, family planning and the ability to time and have a healthy pregnancy is absolutely integral to the life and health and really, you know, economic sustainability as well for women and for families. And so started a clinic to integrate family planning into the chronic disease care that we have. And that has moved with us from its initial location. I think this picture was in the basement of one of the old Ampath buildings, and have now moved into the Chandaria hospital that was built and has really been well integrated into all of the chronic disease care that we provide for women. The other two pictures are of some community projects. So the one on the top is from Port Victoria. You know, I think, again, one of the great assets of Ampath is that we don't only stay in Eldoret in the hospital. We get to go out into the communities because we know that that's where the people are, and that's where our initiatives are really best placed to make a difference in people's lives, by going to them and using the people in their community that are trusted advisors. So working with the community health volunteers on the right is a session that we held for kind of understanding the journey that women take in being in their home and needing support to be able to identify a pregnancy or know when they're pregnant, so that they can seek care both in the pregnancy itself and in getting family planning to avoid a pregnancy when they don't want to be or would be unhealthy for them. And so we created a CHV-led initiative to provide urine pregnancy tests and the counseling necessary to create those referrals and linkages to care. And so these are just some of the examples of the way that we, again, you know, work to strengthen both the facility level and the community level care. And I'll pass it to Julie now. Julie, you might be on mute.
I am. Thank you. I was just saying, I have a few pictures, so I'll cue you for the slide changes. And you know, I have to say, very much from living as a team leader and being able to interact with our medical students and registrars, and even, you know, I feel like Gay and I graduated around the same time, so I feel like we're, you know, compatriots and moving through our early careers together. I've been really impressed at the number of sort of younger, earlier career people coming forward who really have a bit of an impatience and excitement and drive to change care, and a passion for people who need it the most. And so I really think in gynecology, especially in Eldoret and Kenya, we're poised to see some really awesome changes in the future. COVID pandemic aside. But what I want to do here is talk and focus a little bit on adolescent reproductive health. And so in the last couple of years, especially adolescent sexual and reproductive health, or SRH, has really taken a spotlight on the international stage. I do have lots of statistics that I could share, but for the purpose of this, I want to tell you a really typical story. This girl, her name is Faith, for example. She's 15 and she likes to wear her hair in long silver tipped braids when she's not in school. She likes to hang out with her girlfriends. She doesn't have a lot of money, and her family of 6 share a one-room apartment. There's a boy she likes, and sometimes they sneak off on the way home from school for sex. Or wait, no, her uncle, who has moved in with them looking for a job, he drinks too much alcohol and he rapes her when she's returning from running home after doing errands. There's really probably a 50-50 chance it could be either way, or either version of that story. 5 months later, she has a large bump from her stomach and she realizes she's pregnant. So does her school teachers, and she's expelled. Her family threatens to kick her out of the house, so she comes to clinic. But when she gets there, she only really comes once and never goes back, because the healthcare provider who meets her asks her how she let this happen to herself. She goes into labor and ends up with a C-section because the baby didn't fit out of her pelvis. She recovers, she goes home. Her parents let her stay in the house, but every time she goes out, her neighbors call at her for bringing shame to the family. She quit her church for the same reason. She couldn't go back to school because she was afraid she'd be made fun of, and because she needed to take care of her baby. She started working part-time to help someone with their market stall. And that's it. There's so many different versions of this story, and some of them are more horrible, and some of them are a little more supported. But it takes something like that, and you have a young girl who's now a parent who's pretty stuck in her cycle of poverty. And so this building that you see in the background is called Rafiki Center for Excellence in Adolescence and Adolescent Health. And to me, this is the beginning of something really amazing. In efforts led a lot by some pediatrics colleagues like Edith Apondi, Catherine McDonald, Paula Breitstein, and many others, the center was launched in 2015 with a strategic plan to address the needs of adolescents in HIV care, sexual and reproductive health care, and mental health care. And when I was in Kenya as team leader, I was able to get involved in thinking creatively about adolescent pregnancy and adolescent sexual and reproductive health. Can you go to the next slide, please? And so in 2018, I worked with Dr. Mulganey, Dr. Apondi, Heather Miller, and our MNCH Innovations team on a human-centered design project that was meant to redesign a clinic program for the hospital for pregnant teens. We CHVs and healthcare workers to devise strategies and build ideas. Next slide. Instead of a new clinic, we were left with complex opportunities that were meant to address SRH education gaps, stigma in the healthcare facility and in the community, and to find ways to build economic potential and ensure educational achievement for girls throughout the pregnancy and as they are teen parents. At the end of that project, we had a lot of project ideas, almost to the point of being overwhelmed with the idea that we needed to get them detailed and test them out and perfect them so that we could initiate programs. Next slide. With the Chamas for Change team, also with efforts led by Lauren Maldonado, we are designing and piloting a Chamas for Change adaptation for teens, rethinking how pregnant teens can gather for peer education, support, and potential income saving opportunities in a way that's acceptable, desirable, and effective. Of course, this is one of the projects that is stalled by COVID, but we're trying to think about how we can move forward. We're also working with Natasha Ramsey, who's doing her Adolescent Medicine Fellowship, and Maureen, especially from our research team on the ground, and a lot of different students, actually internationally and local, that have contributed to develop a comprehensive sexual and reproductive health curriculum that can be peer or healthcare provider led. Next slide. And so this leads us to some specific training efforts that we've been able to embark on in partnership with the RMNCH program that Dr. Koskei was talking about. Our first program was in December, and we were trialing an empathy-focused healthcare provider training program in adolescent SRH. We held didactic lessons, of course, but we spent a significant amount of time on empathy-driven activities like mystery shoppers and role play, engaging teens as experts in their lived experiences to educate the healthcare providers. We also worked with Ramka to launch a peer navigative training program focusing on SRH so that peers can work with Rafiki Center and also use Rafiki Center as their base, but go out in the community to do outreach focused on sexual and reproductive health and help link them to the facility. And again, we try to engage more empathy-driven and interactive sessions in order to do that training program. And so we hope this is only the beginning, with a lot of room to improve and professionalize these programs, a lot of room to figure out how to monitor and measure these programs for impact, so that when we have girls like Faith, we're able to shape them or help them shape a new and a more empowered narrative. And that's all I wanted to say.
Thanks, guys.
Really.
Whirlwind tour here of I think you've done a really nice job of weaving together just how integrated all the sort of the care and the education and the research programs really are part of a sort of a more holistic approach. I think, Caitlin, were you going to say a little bit about a COVID project too, or?
Yeah, I mean, I think, you know, what we really want to say is that, you know, COVID is changing the landscape in a lot of ways, right? I mean, I think what we are seeing internationally and what the data is showing is that the deaths from the lack of care is really going to be much more than the number of deaths of COVID, which is really the scary part. I think when we know that clinics are closed or people are scared to go to clinics, and many young children are at home and potentially unprotected by kind of the environment that school gives them, we're seeing rises in teen pregnancy and sexual violence and domestic violence. We're seeing rises in maternal mortality and unsafe abortion because of all of that. And so I think we have an opportunity to think about what our responses are going to be, you know, as an organization and as individuals, to see what we can do about it. And there's a lot of work to be done.
Thanks.
Kosuke and Riga, I don't know if you want to speak briefly to your experience of how COVID has impacted reproductive health care.
I think I'll go first. So for sure, we've had an effect from COVID. On average, we would per month be delivering around 1,100 women within our facility. And during the periods of March, April, and May, that dropped to around 700, which already shows you a decrease in the number of people who had like safe deliveries. We also had a decrease, and you can actually see in our plot when we are calculating the contraceptive, sort of a CYP couple year of protection, we've actually had a drop. If you look at the line graph, you actually see a drop in the number of people who are able to access family planning. We've also seen, interestingly, sort of like an increase in the number of adolescents who have died from delivering in unsafe environments. That does not only affect the care per se, even the commodity supply chain. So availability of FP commodities has been a challenge. Availability of sometimes basic supplies. Recently, I think within Eldoret town, there was almost a shortage of gloves. We had to wait like sort of like 2 days before we could actually access just normal gloves for patient care. So we've actually had the landscape change a bit, and I do agree with Caitlin. The deaths that we might have from the restrictions sometimes from COVID have made it worse. We've also had challenges, and sometimes we've had to come and overcome these challenges. Because of curfews that were enforced by the government, and a bit of the overzealous protection of the curfew by the security personnel, women were also unable to access care. That means if you are laboring at night, getting access to a facility became a problem, and that explained also the decrease in facilities. Available vehicle or carrying transport mechanisms, having a taxi driver to come and take you to hospital, a piki, or even just traveling at night was unsafe because you could get manhandled. So this also affected women accessing care. So yes, in short, we've definitely had affection in terms of service provision, specifically for reproductive health, because of the COVID pandemic.
There's a few questions here. I think probably Kosuke is best placed to answer them. Do you have an idea of what the percentage of women in the community who give birth in a hospital versus a community setting are? And if they have high-risk pregnancies, are they referred to MTRH?
We have, I'll give two scenarios. So nationwide, our SBA, that means skilled birth attendance at birth, is around 66%. So we do have around 40 or slightly more. That has actually come up. It used to be around 56. So we do have around 40% of women delivering within the home, which we consider not to be healthy. I'll give two examples. We've had, this is just in the couple 2 weeks. We've had a mother who was attending clinic for the first time. We don't know whether she didn't attend clinic because of either lack of knowledge about ANC or just because of COVID issues, but came to a peripheral facility with blood pressures of around 192 over 120. By the time she was being referred from the peripheral facility, midway or in the process of being referred, she ended up having a stroke. She came to our facility and was in a bad state, actually had to be resuscitated immediately. Unfortunately, she did not make it. She actually died. And this was a preventable death that we think should have been avoided from the first stage. The second one is a patient who's still currently in ICU. We are hoping she makes it. She's quite sick. She was working as a house help for one of the families. She was working as a house help from one of the families. I think she had an unintended pregnancy. We are not exactly sure what happened, but either through sort of like backward meals, got access to misoprostol, which is sometimes a drug that we use for terminating pregnancy, ended up getting an overdose of termination or an overdose of the medication, came in with a ruptured uterus that had been there for almost 3 days, peritonitis. By the time we were opening up, it was not a very interesting scenario. She ended up with severe sepsis, is currently in ICU. So there is still limitations to access for sure, and even deliveries and basic, we still have a long way to go in short. But yeah, I didn't intend to give very sad. We've also had good experiences, but the past 2 weeks, those are the ones that come to mind.
And it's so important to hear those stories. I think that really highlights the way that, unintended pregnancy, unsafe abortion, and maternal mortality really drive a lot of the difficulties we see and the disparities that we see. Raj is asking about what is the way forward, right? How do we protect against COVID risk while ensuring safe and comprehensive sexual reproductive health care? I think there's some good data that just came out, again, obviously in the US. So, hard to know what the applicability is, that, presenting for prenatal care does not increase your risk for COVID. I think that is information that we really need to get out into the into people, the home, so that people are not afraid of coming for care, that we can put in place proper protections in the clinics in terms of patient spacing and mask wearing, and screening of healthcare providers such that they're not the ones spreading COVID, and in the US we're using a lot of telemedicine for pregnancy care, right? This idea that not necessarily every visit has to be an in-person visit, and trying to be creative with the ways that we reach people, and I think that this is going to be something that will continue on, post-COVID, if there please could ever be such a thing, that we'll continue to use, telemedicine in the best and most resourceful ways. And we already are seeing that with Ampath in a lot of ways in the community, and in our population health programs, and how do we reach people where they are. And so I feel like we're kind of on the front lines of that type of resourcefulness. Another question from the chat is that midwives and nurse midwives are the primary maternity care providers in much of the world. And that, to answer the question, is also the case in Kenya. So as Kosuke mentioned, 13,000 deliveries a year. That's like something like 3 times Eskenazi Hospital, for those who are here at IU to have an idea of what that volume is like. And Eskenazi, I can attest to going on to labor and delivery today, is quite busy. So it's really much higher volume than any doctor could handle. And so for the majority of deliveries is by a nurse. And some midwives as well, but mostly just nurses. And then with the specialist OBGYNs, the registrars, as is the position of Riga, and consultants in Kosuke's position that are overseeing the more complicated cases are available for emergency care that would be above the level of a nurse. And she says, in terms of training of healthcare providers, oh, go ahead.
I can add.
Yeah.
No, I was just going to say, and I guess, you were going to speak to this on the training, like, through some of the early initiatives led by Astrid and Hansen, there's at MOI, there certainly has been efforts in starting and continuing emergency obstetrical training. Ronka has been doing that, and there's an initiative out of the department that I'm sure Kosuke can speak to have our nurses who are really highly skilled with the volumes that they do at MTRH to go out to the smaller community sites to do mentorship. And so there's a few different avenues we're trying to provide. Additional emergency obstetrical skills and auditing and mentoring efforts are underway.
Yeah, absolutely. Raj says that we should all be wearing face shields. I can't attest to that, but I think that probably sounds like a good idea. Maybe Adrian can be on top of that in terms of PPE distribution. The next question was about disparities and kind of what lessons we have learned here in the US that we translate in Kenya. And I think, yeah, I mean, it's very bilateral. The challenges that we see in chronic disease care, in family planning care, in high risk, obstetrics care is all the same. And I think, the challenges and lessons that we take back and forth constantly. Julie can attest to that in her adolescent care work, right? That the stigma that we see about adolescent pregnancy and the care that they sometimes receive in the health facilities is very similar, and much of the work needs to be the same back and forth. And I know that we're working on kind of local, global initiatives. Dr. Litzelman works with the We Care program here in Indiana, for example, that uses many of the models that we have in Kenya for community health volunteers. This idea that, we are not here in the facility, in necessarily the best place to be able to reach people, that there are others on the ground in the communities that we can train and work with and learn from that can be best placed to do that. I don't know, Kosuke, if you have any thoughts about kind of from your experience in North America back and forth.
I think I'll give 2 examples. I think North America, I think, and especially because of the electives that we had in North America, I think it assists us to have a vision and sort of work on a mission, because you could sort of see where you have low maternal mortality rates, what they have done to try and reduce the maternal mortality rate. And that helps us come and see what can be implemented into our context to be able to try and reduce the maternal mortality rate. However, it is, and we've also realized you don't have a silver bullet for this. There are a lot of things there are a lot of factors that come into maternal mortality rate, both from the patient and also within the institution and healthcare providers. We have tried to, if you look at our maternal mortality rate within Kenya, probably within a month, 2, if we are on the higher side, we are trying to reduce this, but this is because it's a referral hospital. You have access to slightly more resources as we compare to the county facilities. But there are a lot of things. If you look at the 4-delay model, then that gives you a good idea. There's a thing about educating the patients. You need to improve them in terms of decision making. We probably need to support them in terms of having resources that way, even if they decide they're coming to hospital, then they have the money to come to hospital. Also attending for ANCs, and also generally there's also a bit of community, cultural, social cultural activities that still affect. Also availability of commodities, training. So I'm not going to say that we're going to have one specific bullet. I do, however, can say that we seem to have had a reduction in terms of women who are dying from PPH, but I suspect this is mostly because of the efforts that have come into place and the training. But we are seeing an increase in the number of women who are dying from chronic diseases, and specifically hypertension in pregnancy. So even with the reduction in mortality a bit, there's also a change in the environment from the causes of death. I think that is what I was going to mention.
And we see the same thing here in the US. You can think of Indiana as like, you know, Indianapolis is Eldoret, right? And there are lots of rural areas very far from the facility, you know, with lower level facilities that really just do not have the resources, either the expertise in terms of the physicians themselves, you know, the timely surgical services, the medications necessary to be able to take care of these high risk. And where here we have Lifeline, right? We have those beautiful helicopters that go out and bring the babies back to Riley and the women back to Methodist for that type of care. That's not something that we have in Kenya. And so when you know, think about somebody with obstructed labor or hemorrhage or a stroke, you know, we're talking, you know, hours or days before they can come to us at the facilities instead of, you know, the minutes. I've just put up a picture of the 4 delays model if people aren't familiar with that. And I think it's really a great way to think about you know, all of the things that we need to be hitting on, right? We are not just able to, again, stay in the facility and have the care here. We need to address all of the delays in the different ways that we can meet people where they are. One of the questions from Sonak was about, oh, go ahead.
Underline. I think we have a lag, sorry. I was just gonna say, we can't undermine, as you know, especially in a country like Kenya, how there is need for, you know, good upper levels of leadership, right? We have women who are having a hard time getting to hospital at night because then the tattoo drivers are worried about getting arrested, and that's something we have, you know, for driving outside of curfew, and that's not something we have a lot of control over, and need systems in place at a much higher level. You know, we need better road infrastructure, and the road infrastructure in Kenya has improved amazingly, you know, but that comes from higher levels. We have contraceptive commodity shortages, and there's a system in place to try to provide those, but it's under duress right now. And so how can that be better supported? And all of those things would go to contribute to helping these delays, in addition to the educational outreach and healthcare provider training and improving healthcare provider to patient ratios that we're working on.
Yeah, Bet makes a good point in the chat that we need to be embracing social media. I think Julie, you know, in her work with teens is really doing some of that. I don't know if you want to speak to that. And also if there's anybody on from the Chamas team, you know, they've been doing a lot on radio in Kenya, like these spots all of the time, talking about, you know, different aspects of prenatal care and how people can recognize emergency signs and come to care. And so I don't know if you want to talk about that, Julie, at all.
I mean, I can a little bit. We've talked about trying to make a Rafiki hosted Facebook group, and I think we're still in the process of making sure we have appropriate hospital approvals and the right moderators for it. We do worry a bit, you know, there's a lot of interesting social media oriented initiatives for adolescent SRH, because you're right, this is, you know, Twitter, WhatsApp, all of these, Facebook are where teens can get information, but the vast majority of teens that I interacted with did not have their own phone, and the phone they had access to was simple phones. And so, you know, there was a population that we could make WhatsApp groups with, but there was another population that we still had a hard time reaching, and so trying to figure out what our best platform was. It's still kind of a bit of a challenge, and still seems easier to get people together in person, depending on which demographic we're trying to reach.
We just have a few more minutes. I did also just want to, of course, put a plug in, that we really appreciate all of your support and need your support to continue being able to do what we're doing. I know here at IU, we're trying to raise funds to have a chair position so that we can have a full-time North American on the ground in Kenya, as well as, support the leads in the programs to be able to continue programming and continue, to improve all of the reproductive health care that we can. And in addition, any support that you can provide to Ampath overall as an organization, will go to reproductive health in addition to all of the other work that we do.
So we might have time for one more. I don't know if you guys want to say one more word, Julie or Caitlin, about your how you apply what you've learned in Kenya here domestically, or.
Yeah, I think, yes, sorry, thanks. So next question. I mean, for me, it's really about, much of the maternal mortality that we see now in the US is really driven by women with chronic disease. And so understanding how we can support them in family planning care to prevent a pregnancy until they're healthy enough to have one, and supporting them through difficult pregnancies, and trying to reduce maternal mortality in that way is I think my biggest takeaway from working in Kenya.
I don't like Sonak's one thing. It's too hard because they're all overlapping. The perspective of care that I was able to walk away with has taught me this interesting mix of patience and impatience with our healthcare system, where it does take me a lot to get excited about certain medical things that we address clinically, but I also get impatient with maybe some people's impatience. It gives me a lot of perspective as we think about how we have done wrong in our advances of Western medicine, especially when we think about certain disadvantaged communities and the idea of cultural competence in pregnancy care and bringing pregnancy back to and delivery practices back to communities that have been wronged by our healthcare systems, and a much better expanded scope on to think creatively around problems, and some frustration with the bureaucratic tape that is in place as a result of the systems that we have here.
Well, we have reached the end of the hour, but I hate to cut off all this discussion because it's a great discussion, and you guys have done just a wonderful job of sharing your experiences and how the impact of your work is really affecting not just the medical determinants, but really the social determinants of health. And I think that's really one of the lessons that we are so important, that we draw from Kenya and then we bring them back here and we see the same social determinants really driving these processes. So. Just want to thank everyone so much for tuning in. This as Caitlin said, this work really relies on the support of people like you, the donations that you make to Ampath. And if you're interested in learning more about how you can learn more about some of these programs that you heard about today or support them, please reach out to us. We're more than happy to connect you to individuals and continue these conversations. I want to just put a brief plug in for our next monthly chat. Will be on short-term medical missions. Jenny Benziger and Dr. Palka Patel are leading the title that how to maybe help people and not be a jerk. So if you want to not be a jerk, you kind of got to tune in next September 3rd.